Hello. All right. Let's discuss today the issue of how do you survey for blood tests in rheumatic diseases. We'll start with that and we'll go on to other forms and imaging.
Dr. Bernhard, can I just make one quick announcement? Sorry.
Yes.
Thanks all for attending and being part of the MAVEN Project. We want to especially thank our friends at the Puyallup Tribal Health Authority. I'm sorry if I pronounced that incorrectly, who serve eligible American Indian and Alaska Natives living in Pierce County in the state of Washington for hosting today's session titled Choosing Wisely, Tests and Imaging for Rheumatic Diseases with Dr. Gerson Bernhard. Dr. Bernhard is a clinical professor of medicine at the University of California at San Francisco. He retired from his own practice after several decades in both community and academic practice of rheumatology in Wisconsin and Northern California. Since then, he has continued precepting rheumatology fellows at Stanford and UCSF and instructing medical students as well as physicians, nurses, practitioners, and physician assistants. He's been an advocate for the comprehensive care of patients with rheumatic diseases, and in the past headed a 24-bed inpatient rheumatology unit. The American College of Rheumatology has honored him with the Paulding Phelps Award for service and education and made him a master of the college. With that, Dr. Bernhard, the screen and mic is yours. Thank you.
Okay. Sorry to be so late. However, let's review the issues that I often get when you ask for consultation, because it's difficult sometimes to interpret the tests that you receive or the imaging that you get and apply it to your patients. And I understand this is a problem, but because these tests can often be very confusing. And what do I do with this data? So with that in mind, I decided, well, let's look at the commonly used tests in primary care, because some of these more complex or sophisticated tests we might request or ask you about later after you presented your basic information about the patient. And there is the real issue as far as I'm concerned. You need to be able to tell us all the clinical information that you've been able to accumulate with your patient, because that will help us decide which tests are useful and how to apportion this information into the clinical decision making. So what I'm really telling you is that these tests and even some of the imaging are not necessarily very specific to a disease, and so they won't give you a printout. You know, it's relatively easy if a patient comes in with a certain set of even sort of vague symptoms, and you get a panel and you see that their blood sugar is high or their A1C is high, and you can say, well, I can assign most of your symptoms or your problem to your diabetes, and you have diabetes, and we will proceed from there. With rheumatology, it's not that simple. And these tests very often are not diagnostic, though they give us information either diagnostically, but more prognostically than diagnostically. And they sometimes do not necessarily follow the course of disease. So let's look at some of the more common ones. The most common thing and very specific, of course, is the basic stuff. Blood count. Please tell us, about acute phase reactants. Those are sedimentation rate, CRP, and even platelet count. So if your patient comes in with a lot of rheumatic arthritic complaints, rash, arthritis, just arthralgias, and you are suspicious that they have an inflammatory rheumatic disease, then your basic stuff is see what that blood count is, see what the sed rate is, and see what the CRP is, and even a platelet count. An elevated platelet count actually can be, and often is, an acute phase reactant, and gives you a clue that, yes, indeed, we're dealing with someone who has an inflammatory disease. Then commonly I see rheumatoid factor. Well, rheumatoid factor is excellent for certain things, and indeed, it does tell us probably 60% of patients with an inflammatory polyarthritis that yes, they probably do have rheumatoid arthritis. However, there are a lot of other issues and a lot of other disease processes that will give you a rheumatoid factor. And so we will go down with some of these in sort of in order and try and sort out their value. So let's just look at the rheumatoid factor itself. Yes, someplace between varying reports, but on average, about 60% of patients with rheumatoid arthritis will be positive with rheumatoid factor. But look, here's Sjogren's syndrome, mixed connective tissue disease, mixed cryoglobulinemias, lupus, poly or dermatomyositis. Even those have 5 to 10% positive rheumatoid factors. Chronic liver disease. And in the normal population, about 5% of the people, especially as they age, will have a positive rheumatoid factor. So it's really a nice test, but it's not very specific. And here are some other other disease processes that are associated with rheumatoid factor positivity. Look at bacterial endocarditis, hepatitis B, or even hepatitis C, TB, syphilis. All of these can give you what I would call a false positive rheumatoid factor, because what you're looking at with the rheumatoid factor is antibody, or actually a group of antibodies that are in the category of IgM, or large immunoglobulin molecules. It also is present in pulmonary diseases, and these people do not necessarily have rheumatoid arthritis. So much for the rheumatoid factor. Let's move on. So it's useful, but it is not diagnostic. So your patient who might even have fibromyalgia and has a positive rheumatoid factor may have some other disease process going on. Now, what about the so-called CCP, or anti-cyclic citrullonated protein? Therein, we have much more sensitivity and much more specificity for rheumatoid arthritis. So if clinically you think your patient has a bilateral, symmetrical, inflammatory polyarthritis on the basis of history and on your examination, indeed, this is a test that can help you include or exclude rheumatoid arthritis. And the other one that sometimes is done in some laboratories is the anti-vimentin, which is another associated antibody, but rarely do clinical laboratories do this. So you're looking at CCP as being a more specific test, and that can help you, because if it is negative and you don't have good clinical features of RA, but you have clinical features of other connective tissue diseases, you can move on. So where do we move on to? Well, the next commonly done is the anti-nuclear antibody. And I see positive anti-nuclear antibodies tests being reported with your clinical referrals. And it's sort of, well, a patient has a positive ANA and it is reported on a titer of 1 to 160. What do I do with this? And what you do with it is to begin to say, well, does it fit into a clinical disease process? Now, the ANAs are done usually in two different patterns, or two different ways. One is that they do an immunofluorescent test, And you will know that it's an immunofluorescent test because if they report a titer and they report a pattern, that pattern is seen on immunofluorescence. If instead they just report a titer, it may have been done by an ELISA testing technique. And if that ELISA technique is fine, and it's quicker, it's easier for laboratories to do. However, it is not as specific. And therefore, you have another issue or a potential issue coming up, which is a technical one. However, let's look at just the ANA itself. When is it positive? Well, in a high percentage of patients who have systemic lupus erythematosus, 98 or so percentage. And even in remission, those patients may continue to have the positive antinuclear antibody. So it doesn't follow the course of their disease, but it also is present in a lot of other connective tissue diseases like scleroderma, drug-induced SLE, Sjögren's syndrome, rheumatoid arthritis, even 40–45%. Patients who have Raynaud's phenomena, but no other evidence of clinical evidence of rheumatic disease, patients who have poly or dermatomyositis, and certainly in some patients who have juvenile idiopathic arthritis. So it, again, is not specific to systemic lupus, though it is most sensitive to systemic. Putting it another way, if you have a patient who presents with clinical features that you're wondering they might have SLE, but the ANA is consistently negative, then you better look elsewhere or further. It is also positive sometimes in a small a percentage of patients with EB virus, HIV virus, HCV virus, and certainly in parvovirus patients. So again, occasionally we'll see positivities in malignancies or inflammatory bowel disease, but those are usually low titer. And when they report a pattern, they will tell you it's sort of a homogeneous or diffusely speckled pattern. So that helps you in sorting patients out, but it is not, again, specific. So what is, I hope that let's go back to our original slide. So we've got to all this point, this part. What is more specific, if you have a patient who has clinical features of systemic lupus, a positive ANA, then the subserologies become important in terms of relating to the specificity of their disease, but relating somewhat to some of the characteristics of their connective tissue disease. There are a lot of patients who will present and you think they have SLE, but they have some subtype of SLE or something closely related to it. And that's the point at which we will then probably ask you to get subserologies, including complement, so that we can have a better idea of how to direct you in terms of referrals and in terms of treatment. Often I get the story that, well, yes, I want this patient to be seen by a rheumatology, but that's going to be 3 or 4 or 5 months from now until they get in. What do I do in the meantime? Which direction do I go? And that's when we can help you in terms of that. Now, let's look at other things. Muscle enzymes. If you think your patient has an inflammatory myopathy, and that's not uncommon and occurs even in a small percentage of patients who are on cholesterol-lowering agents, and it's not frequent, but it does occur. And you really want to look at simple enzymes, CPKs, and aldolase. If they are normal and your muscle testing is pretty good, you better look further for other explanations of why the patient has weakness. We can also use the anti-neutrophilic antibody, so-called ANCA. So let's go on to the ANCA and see where we are with that. So this anti-neutrophilic cytoplasmic antibodies is an indirect immunofluorescent way of, you can measure it. Depending upon the pattern that is seen, it is either so-called C-ANCA, which shows immunofluorescence of the entire cytoplasm, or a P-ANCA, which is only perinuclear. And originally it was thought, well, this really separates diffuse granulomatous vasculitis from other forms of vasculitis. We now will be using an ELISA enzyme-linked immunoabsorbent technique can more specifically look at proteinase 3s and myeloperoxidase. What's the reason for doing that? Well, most of your laboratories now, if you order an ANCA, will not only give you this immunofluorescence test, but they will give you this additional information. And this proteinase 3 seems to be more specific for granulomatous vasculitis and eosinophilic vasculitis. And so we use that not as a diagnosis per se, but to help classify the characteristics of the vasculitis patient that we are seeing. Whereas myeloperoxidase can occur for a variety of reasons and not necessarily, pardon me for going ahead, not necessarily a large vessel vasculitis, but may occur with small vessel vasculitis and some of the vasculitises that occur as a consequence or reaction to medications. So if you get that far that you have a positive ANCA and you have some diffuse connective tissue symptoms and you're suspicious the patient has vasculitis, clearly you have to give us all this information. And this is good information to pass on if they're going on to a rheumatology evaluation, whether it's with us or a rheumatologist locally in your community. So that, I think, covers the overview of blood tests. The real test that relates to a lot of arthritis diagnosis is the evaluation of the synovial fluid. This is where you really get a clue as to whether that patient who comes in has a swollen joint or two, or even multiple joints. You can specify which kind of arthritis they may have. What are you looking for? If you can, and I would urge that even in primary care, you learn the technique of being able to aspirate large joints, such as the knee. It's not very difficult. A patient who has comes in with swollen joints, even if it's a specific, and particularly if it's a specific or localized joint and it's a knee, if you can learn to aspirate that and put it in a simple anticoagulant tube and send it to the laboratory, they can do a cell count. They do a differential. Nor the kind of fluids that you see in patients who have, say, osteoarthritis will have a very low cell count, probably less than 250 cells per ml. And you can look at the fluid and you can see that it is clear. You can feel the fluid and it feels like a number 10 oil. In other words, it has some oily characteristics to it. If it's a cloudy looking fluid, and the cell count is elevated and it feels sort of watery, you've got an inflammatory process. And what do you want to need to know about that? Well, you can do a gram smear on it and a culture. Unfortunately, the percentage of positives in patients who have a septic arthritis is relatively low. However, if it's positive, this is very, very specific and diagnostic. But more importantly and more commonly in your practices will be the patient who comes in, has one or two acutely inflamed joints, and you're suspicious that they may have gout or they may have chondrocalcinosis, so-called pseudo-gout. And therein, the joint fluid is truly diagnostic. I know that it's common in a patient whom you suspect gout, you get a serum uric acid, and if the uric acid is elevated, well, then that must mean they have gout. There are a lot of reasons for elevated serum uric acid, and just to make things more difficult, there are some patients in the acute phase, maybe the first or few times of their acute gout, who will actually have normal serum uric acids, yet they have an acute swollen joint, which is indeed gout. The proof of gout is to get inflammatory fluid that shows intra and extra-articular crystals under polarized light. And a good laboratory can distinguish between urate crystals and calcium pyrophosphate crystals. For instance, if you looked at my joint, when I get a big swollen knee, I know it has happened on 2 or 3 occasions. I will have lots of calcium pyrophosphate crystals, intra-articularly elevated cell count, and it acts all in the same way clinically as does gout. But this is classic pseudo-gout. So finally, before we have discussions and so forth, I'd like to make some points about imaging. Plain films, if you get films of your hands and feet, you get a lot of joints per film. So looking at it very efficiently, both in terms of diagnosis and utilization of services and keeping costs, get hands and feet. If you have a suspicion the patient may have a inflammatory axial skeletal disease, such as ankylosing spondylitis, or the spondylitis associated with either psoriasis or inflammatory bowel disease, a simple AP pelvis will give you a clue. And what you specifically have to do is tell your radiologist, I am concerned this patient has an inflammatory axial skeletal disease, because, and this is particularly true in women, you will sometimes see osteitis condensans ilii on the ilial side of the sacroiliac joint on a simple AP pelvis film. There is not a lot of radiation there. You don't necessarily need and probably shouldn't get a full lumbosacral spine film, which has a lot of radiation, because there'll be a lot of non-specific changes that you may observe, particularly if the patient is in their 50s or 60s. If you are going to get films of your knee, of the patient's knees, please ask them to do weight bearing and a sunrise. Weight bearing gives us a clue as to whether or not the joint space is narrowed, which means that there has been erosion of cartilage, even if there's little or no sclerosis or osteophytes or obvious changes of advanced osteoarthritis. And by the same token, you get a sunrise view, you get a view then of the patellofemoral joint, and it gives you an idea of whether or not there are erosions or changes there. Finally, I would say, frequently, if you have a patient who has an inflammatory rheumatic disease, please get a chest film for a variety of reasons. A lot of our diseases involve the chest. And secondly, you're going to be starting them on, or we are going to recommend that you start them on some significant therapy, whether it's corticosteroids or immunologic therapies. And you need to be sure that they don't have any chest involvement with their disease, but more important, perhaps more or equally as important, that they don't have some other chest disease, such as a benign, or I should say, quiescent tuberculosis, or a fungus infection that is virtually asymptomatic. So you want, now, you'll get the MRI perhaps after you get the plain films, and you'll then require or ask for specific reasons to them. I would urge that you always discuss or get some sort of note to the radiologist of why you want this imaging done, whether it's plain films or an MRI. I don't know whether many of you have access to ultrasound. It can be useful. Some radiologists do a very good job with ultrasound. It sometimes could be virtually diagnostic with patients who have gout. Often, again, you'll get non-specific information. It is also very useful for shoulders to tell you whether or not the patient has torn rotator cuff. So with that, I would like to conclude the formal presentation here and ask you to give me questions so we can cone down and answer some of the issues that you face.
Thanks, Dr. Bernhard. That was a great talk.
So
questions, please use the chat function or the Q&A function, or the raise hand function. Maybe I can ask a question.
yeah.
So in terms of the rheumatoid factor, after what you just reviewed, is there any point in ordering a rheumatoid factor? It sounds like you're not going down a rabbit hole. You're kind of you're presented with like half a dozen rabbit holes you can go down and.
I think the message throughout all of this is if all else fails, look at the patient. The issue is and I know this is a problem in clinics because you're pressed on time, and you sometimes, patients are obtuse and don't come in with a nice clean history and say, oh, for the last 6 weeks, I've had inflammatory changes in my fingers and my little fingers and my wrists on both hands and on my feet. And they don't come and tell you that. They come in and say, oh, I'm hurting. And it's up to you to then pull out from them, is this inflammatory arthritis? Are you having morning stiffness in those specific joints that you're complaining about? Is it lasting 2 hours? Does it wake you at night? Show me which joints you're talking about. And when I examine you, do I find tenderness over small hand joints, wrist joints, metatarsal joints? In other words, all good clinical features of rheumatoid arthritis. If I find something like that clinically, then going to rheumatoid factor may be useful. but then you have to interpret it and make sure you've excluded all the other reasonable possibilities. So as a survey, you're right. It's not very useful because it's a sort of a scattershot. If you really think this patient has rheumatoid arthritis or might have rheumatoid arthritis because they present with features of inflammatory polyarthritis, have an elevated sedimentation rate and commonly modest anemia, yeah, then I would say, okay, you can get the rheumatoid factor and you're going to be 60% chance of positivity. But if you also get the CCP, you have a much higher chance of sensitivity and specificity. And that will help you a great deal. What happens if you say, well, I got the rheumatoid factor and it was a low positive, but the CCP was negative, and then you go back to the patients, well, are you having any rash? Do you have dryness of your mouth? Do you have other clinical features suggesting a different kind of connective tissue disease or some other disease altogether? So it falls back on taking the time to do all of that. And I understand that that's a problem with time, because if you can get a rough idea of the patient's problem and draw some blood tests that gives you the answer, it's quicker, more efficient, and you can proceed. But unfortunately, with rheumatology, we aren't able to do that, with the exceptions, as I said, with synovial analysis. If you get the joint fluid that shows you a high cell count and some crystals intracellularly, this is gout or it's pseudo-gout. If, on the other hand, it's this high cell count and the patient has symptoms suggesting of infection, and you get anything further suggesting infection, i.e. a smear or a culture, you have a diagnosis and you can rapidly proceed. So there are a few things like that that are really all that specific. So to go back to what you suggested, yeah, rheumatoid factor is not a good survey.
We've got a number of questions in the chat. Are any tests helpful for for folks who have myalgias and arthralgias in the setting of long COVID?
Ah, unfortunately, no. In long COVID, there are, the long COVID patients come in looking very much like patients who have fibromyalgia, and there's a big overlap here. And here you are with us all at the edge of knowledge. I've just recently reviewed all of this with my friend at Cleveland Clinic, Dr. Calabrese. And here's where we have a major problem. We can describe the patient who appears to have long COVID. They have widespread aches, pains, great fatigue. They don't feel well. They have myalgias. Uh, and they're not dreaming about this. This is not something that they want. They would love to get rid of it all. And it seems to hang on with it, and is perhaps made worse, shall we say, or more frequent, I should say, for the patients who did not get treatment and who had multiple episodes of COVID. And it overlaps with patients who also have fibromyalgia, because the fibromyalgia patient has diffuse aches, pains, and stiffness without specific joint pains. Or they may tell you that they have joint pains, but it's diffuse. It's not localized, associated with swelling and stiffness of specific joints. And therein lies the clinical differentiation of patients who have long COVID, patients who have fibromyalgia, from patients who have inflammatory diseases like rheumatoid arthritis. If you look at the laboratory patients who have long COVID, you usually find that the sedimentation rates are normal, very common. Usually their blood counts are normal, their urinalyses are normal, and their rheumatoid factor is going to be negatives, or again, rheumatoid factor is not a good survey. If you are concerned that maybe you're seeing a patient who's drifting into or has early rheumatoid arthritis, again, the CCP is more specific. And in virtually all the patients who I know of with true long COVID, this will be a negative. I hope that helps explain it.
Yeah.
Long COVID has become a real problem for a lot of clinics and a lot of physicians because it's difficult to treat and it's difficult even to diagnose.
And there are a lot of patients with it, unfortunately.
Uh, well, when you consider that there may be 5 to 10% of patients who have long COVID, but the volume of people who have COVID is large, so that means a fairly common disorder.
Next question. Is it still true that acutely lowering uric acid by starting something like allopurinol can precipitate a gout attack?
Yes,
Okay.
if you have proven gout and you're putting a patient on a uricosuric agent, in other words, an agent to lower like allopurinol or febuxostat, then you want to be sure that they have some prophylaxis along with it. The simplest prophylaxis is colchicine. 0.6 milligrams once a day usually is enough to keep that under control. Then you say, well, okay, that's fine. How long do I have to do this? I've got this patient who has gout. I don't need to have them go off to the rheumatologist for all of this. You can manage it in the primary care setting very well. You put them on the appropriate dose, let's say of allopurinol. At the same time, either put them on the colchicine, or you can use a low dose of an NSAID, such as naproxen once a day. And they can do that with a leave over the counter if they want. How long do you do this? Well, you're going to be monitoring their serum uric acid. And it's going to take you several months of your uricosuric agent, your uric acid lowering agent, to get them down to a serum uric acid level of less than 6.0, which is really the goal you want if you can achieve it. You want them to keep them on the prophylaxis all through that, and maybe even for a few months after you achieve that. Then you can drop it off and keep them on the uricosuric agent for literally the rest of their life, because they have a metabolic defect which will allow that uric acid to rise up again and produce more episodes of gout and the other complications that are associated with gout, which are cardiovascular as well.
Okay, great. Next question. One of our providers has a 23-year-old female with ANA, a very high ANA, 1 to 1,240. The patient has Raynaud's and libido reticularis. She doesn't complain of pain, doesn't have leukopenia or thrombocytopenia, nor no oral ulcers. The question is this still Raynaud's causing the positive ANA, or is there something else?
I would be suspicious that that patient is in the early stages of SLE, because Raynaud's is common in SLE. However, there are other possibilities, because Raynaud's is almost certainly present in patients who developed diffuse scleroderma. So look at the patient very carefully in terms of other connective tissue diseases, specifically lupus and scleroderma.
So
That's the patient who I would say you want to proceed further. We would do that high titer, check the urine, because make sure that they don't have protein in the urine and don't have red cells or red casts in the urine. So follow the renal function very well, and know and keep looking clinically for signs and symptoms of lupus, but also for scleroderma, more than almost the other things. That's a patient in whom I would say that's worth referring to rheumatology, because the rheumatologist will then probably look at the patient both, we hope, clinically very carefully, but will then order the subserologies and begin to more specifically categorize this patient, which is of some value therapeutically, but more importantly, prognostically.
would this
I
be a
hope that,
patient you'd order subserologies?
well, you could order the subserologies at this point and see what comes back on that. That would help you in terms of the subsequent referral. And the subserologies you want are going to be DNA. If you ask for a lupus panel, they'll give you SSA and SSB and DNA and ENA, et cetera. Most laboratories like to give you a whole panel. What you will do with that information is another question. And that's the kind of patient you would then ideally at least refer to one of us on the rheumatology panel of the MAVEN Project and or to your local rheumatologist, because you now have a patient who is developing a diffuse connective tissue disease. It needs subcategorization. It needs following. It may need some therapy, and that's the kind of patient who sometimes responds very well in terms of not progressing on an antimalarial. However, if they're progressing to systemic sclerosis, the earlier that's identified, the better as well.
Another, I guess it's both a comment and a question, is that I've often found that in primary care, patients with erosive osteoarthritis are the responsibility of primary care and not rheumatologies, which is fine. But beyond pain meds and physical, PTOT, is there anything else to offer these patients who can be greatly disabled by erosive OA? Is there anything new pharmacologically on the horizon?
Erosive OA occurs fortunately, in a very small percentage of patients with osteoarthritis. And is really uniquely identified and involves the distal and proximal interphalangeal hand joints. I don't think I've ever seen a patient who has erosive OA in the foot, and when they do have what sometimes might be considered erosive OA in the foot, it's really progressive OA, and some of these patients, those are really pseudo gout or so-called calcium pyrophosphate crystal disease. But going back to the patients who have erosive OA in their hands, they can have a lot of apparent inflammation and in those finger joints, and it becomes quite disabling. The anti-inflammatory drugs that we've used, of course, have been and fall back on the non-steroidal anti-inflammatory drugs. And hopefully your patient can take these and doesn't have any contraindications for those. Analgesics are obvious. There is some suggestion that maybe antimalarials, i.e. hydroxychloroquine, in doses of less than 5 milligrams per kilo daily, are somewhat helpful. There have been no good clinical studies to demonstrate their value or their non-value. I don't know of any other agents that are useful for erosive OA. And unfortunately, I don't see any real good clinical studies on pharmacologic therapies for it. I think there have been some small studies trying to use the TNF inhibitors, and that was negative. So that's not particularly helpful. And you really don't want, yes, if you gave the patient corticosteroids, they're going to probably feel better, but you really preferably do not want them on large, on even modest doses of, say, prednisone. And you're talking, you almost certainly with an older age group patient who would have further osteoporotic issues with even low doses of prednisone. It's a tough therapeutic problem. I can't disagree with you.
Great. Dr. Bernhard, going back to that patient with that ANA of 1240, ANA titer of 1240. Titers in that range, 640, 1240, and higher, can those types of titers be caused by things like chronic viral hepatitis or cryoglobulinemia or other quote unquote non-rheumatic diseases? Or when the titers get that high, should we be thinking about autoimmune diseases first?
Yeah. The answer to the question is yes, it's possible, but no, it would be rare for other disorders. If you see a patient who has that kind of titer, and particularly if they have any other symptoms or clinical features of a diffuse connective tissue disease, the answer is they have a diffuse connective tissue disease until proven otherwise. So you need to then pursue it much further. And what do you pursue it with? Well, a lot of ways. In terms of imaging, these are the people who should have a chest film. And if there are any pulmonary symptoms whatsoever, they may very well, it may be very necessary to go on and get an MRI or a CT to see whether they have any pulmonary fibrosis, and if so, what the character of that fibrosis is and its location, and you may need some pulmonary functions. In terms of serologic tests, this is the patient I would certainly go for the sub-serologies, the whole panel, and use that, and also look at muscle enzymes and make sure you do good muscle testing, and absolutely make sure they have good renal function and a good clean urinalysis. And some of those patients you may want to even pursue further with immunoelectrophoresis of their proteins to be able to more specifically subcategorize it. And even if you can't at that point, you're armed with a lot of good clinical and laboratory information, which you've accumulated over a period of probably several weeks. And you're in a stronger position then to say to your rheumatology consultant, you need to see this patient, and perhaps they will not see them in 6 months or 3 months or 2 months, but next month.
Great. And in a pinch, right? Or not, maybe not in a pinch, but to get some guidance right up front would be to make a referral to someone like yourself or any of your colleagues in MAVEN. You know, almost certainly get a much quicker, start on getting the ball rolling and hopefully narrowing down the possibilities. Is that fair to say?
Yeah, one of the things that sometimes we the Maven consultants can do, and certainly I've been in that position, depending upon where the primary clinic is, we can sometimes help expedite the rheumatology consult. We may know of somebody in the clinic. For instance, I've known that this has been true here in California. Somebody up in one of the small communities north, I can probably expedite their getting into a rheumatologist in the North Bay or even down here at UCSF. So it doesn't happen often, but use all the resources you have.
Yep. Yes. Thanks. Any other questions from the audience?
Okay.
Dr. Bernhard, any closing comments that you want to make?
My closing comment would be make sure that you spend the time to really get a good history and a thorough exam. And please give us that information when you refer, because the more information we have along with the laboratory, the more precisely we can help you and direct your next steps, whether they be more diagnostic or begin therapeutic, etc. So more information is always better, and more clinical information is always better, because the laboratory will only support or help you exclude, but it will not make your diagnosis, with those few exceptions that I mentioned.
Great. Thank you.
Thank you.
For a great talk and Q&A. And thank the audience for attending. We hope you've enjoyed it, and we hope you come back for some more MAVEN CME sessions. Thanks again, and have a good rest of your day. Bye-bye.
Bye.